Good evening. On behalf of Sun Pharma Laboratories Limited, I, Dr. Mohammad Shamil, would like to extend a warm welcome to all the delegates who have joined us here for this live webinar on our new product, Nezact, the first powder nasal spray for prophylaxis and treatment of allergic rhinitis. We at Sun Pharma are always at the forefront in bringing the most recent and up-to-date information in the field of medical education to our Indian clinicians. In this regard, today we have with us a leading expert and an authority in the field of allergic rhinitis, Professor Ted Popov, who has joined us live from Bulgaria. Dr. Popov graduated medicine in 1978 from the Medical University in Sofia, Bulgaria. He started his academic career in 1980 in the Clinical Center of Allergology in Sofia. He acquired specialties in internal medicine in 1984 and clinical allergology in 1992 and defended his PhD thesis on airway responsiveness and cough in 1991. He spent 2 years as visiting professor at McMaster University in Canada. He is presently professor at the Medical University in Sofia, Bulgaria, heading an allergy and clinical immunology unit at the University Hospital St. Ivan Rilski. He is a national consultant for clinical allergology of Bulgaria. Dr. Popov has a rich publishing experience. He is the member of the editorial board of a number of medical journals of Bulgarian and international societies, past president of the Union of the Bulgarian Medical Specialists, former president of Inter-Asthma, former vice president of European Academy of Allergology and Clinical Immunology, ECI, international distinguished member of the American College of Asthma, Allergy and Immunology, ECI. Over and above all this, since he has worked very closely with the clinical development of Nezact, I think there is no better person than him to talk on this topic. But before he could start, just to lay down the format for this program, there will be a 25 minutes presentation by Dr. Popov, which will be followed by a 15 minutes Q&A session. I would request all the attendees to put forth your question through the portal. I will screen the questions and to prevent any redundancies and pass it on to Dr. Popov. So I think it's time now to start with our first session. So over to you, Dr. Popov.
Thank you, Dr. Shamil, for this detailed and generous introduction. Good evening to the audience of this webinar. Ladies and gentlemen, I'm very privileged to be able to share with you the experience that I have gathered with this new product, which is something I believe will be very useful in the hands of each of you in their general practices. And I want to put this into the context of the recommendations of the Allergic Rhinitis Guideline Management documents. I'll try to make it sound persuasive, but let me hope I can manage that. So you see the title of my talk on the screen now, and maybe the natural starting point for one such presentation should be the kind of measures that we use for the management of allergic diseases in general. So this is a combination of different measures. Allergen avoidance, as you can see, is always the starting management measure, along with pharmacotherapy, patient education, and allergen-specific immunotherapy. And when we talk about allergen avoidance for allergic diseases in general, we should also look at the ARIA. You know ARIA, that's allergic rhinitis and its impact on asthma. guidelines which also pose allergen avoidance as a starting point for management of allergic rhinitis. So I'll just refer to a study that to an editorial that has been published in 2005 by two of the leaders of the European allergology, Adnan Čustović and Roy Gerf van Beek. So the question was at the time, at the very beginning of the development of this ARIA project, whether measures to change the indoor environment in treatment of allergic rhinitis and asthma are useful. So the basic questions that they ponder upon is, does allergen avoidance work in general? So there's no question about in certain aspects of the allergic disease management, there are so clear examples about the importance of allergen avoidance, and it derives from some very natural things that we witness in our practices. At least in Europe, where you have 4 seasons, it's evident that the allergen avoidance during the seasons that do not have any blossoming plants, people do not have their seasonal rhinitis symptoms. And conversely, if you challenge a person who is sensitive to an allergen with the allergen in the context of experimental work or in the context of those challenge chambers that are now used for research, you invariably can reproduce the symptoms that are a result of this sensitization of the people that have usually allergic rhinitis. And an example of the importance of the allergen avoidance is also related to studies that have demonstrated that reducing the allergen in the home environment of children who are sensitive to house dust mite results in the improvement of their altogether clinical condition. This is by either doing some allergen reduction measures or by taking the children to special places, rehabilitation places in higher mountains. Well, this is clear-cut and straightforward, but yes, but there are cases where allergen avoidance wouldn't work by itself. And these places usually have plentitude of allergens that work in concert in order to achieve their mischievous work, in order to achieve the symptomatic picture of the suffering of the allergic rhinitis patient. So let's focus a bit on the house dust mite avoidance measures for perennial allergic rhinitis. There's a study by Nurmatov and co-workers that was published in the Journal of Allergy of 2012. And they have reviewed a number of studies, and they looked at the quality of the studies and the strength of the evidence. They excluded a lot of papers, starting with 745 papers to begin with. Then they ended up with just 5 randomized controlled trials that they reviewed in big detail. So we have a whole range of whole list of different measures to reduce dust mite and pet allergen levels. So some of those would be encasing mattresses, pillows, and quilts in impermeable covers, washing beddings in the hot cycle, replacing carpets with hard flooring, acaricides and/or tannic acid treatment of the surfaces of the homes, minimizing dust accumulating objects in closed cupboards, vacuum cleaners with integral filters and double thickness bags, removing hot washing, freezing of soft toys. And then you have the pet allergen avoidance, which basically repeats all the measures that I just listed. So what were the inferences of this paper? Trials to date have been small and of poor methodological quality. That's why you had so many papers disqualified from the final analysis. So trials do not allow definitive recommendations on house dust mite avoidance measure in the management of house dust mite sensitive perennial allergic rhinitis. Still, studies suggest that the use of acaricides and extensive bedroom-based environmental control programs may be of some benefit in reducing rhinitis symptoms. And there's now reasonably strong evidence that isolated use of house dust mite impermeable beddings is unlikely to prove effective. No matter how hard we try to keep our indoor environment clean, people don't stay at home all the time. They need to go out, they need to socialize, they need to go to other places, they need to go to social buildings, and then the exposure is there. So individual measures of avoidance are very great importance. There's another interesting aspect of it. We have reviewed some papers on house dust mite and NASAC as a mean to relieve the symptoms of patients sensitive to house dust mite. It appears that at least in certain allergen-rich environments where you don't have only isolated house dust mite allergens and patients might not be monosensitive to those mites, you have a much more complex situation where chronic allergic inflammation sets in all year round. And the mucosal inflammation in those perennial allergic rhinitis patients is self-sustained, and the role of daily allergen contact is not as clear and undisputed as in seasonal allergic rhinitis or in provocation studies. So what's the new perspective that we have? I mentioned ARIA. We have some of the leaders of ARIA who have come up in this expert opinion on pharmacotherapy journal in 2016 with some analysis of the recent pharmacological developments in the treatment of perennial and persistent allergic rhinitis. And they mention, among other things, that relatively new treatments include H3 receptor antihistamines, toll-like receptor agonists. Then they state that its cellulose powders are coming in place, and that they include different substances and compounds, starting with the microemulsion that I'll just mention here, which was one of the first demonstrations of the effectiveness of this type of allergen avoidance measure. And then you have the novel biomolecular formulations like omalizumab. There's another article which is dedicated to barrier-enforcing measures as treatment principle in allergic rhinitis. And it is stated there that the allergic rhinitis and its impact on asthma guideline document states that the patients with allergic rhinitis should be instructed to try to avoid allergens. In this context, barrier-enforcing measures may be viewed as a means to achieve allergen avoidance, and arguably that all patients may be recommended to use such products. And there's a long, don't panic, I won't go study by study here. I just want to demonstrate here that starting in 2000, in the year 2000 onwards, there have been numerous attempts to use substances like white Vaseline, cellulose powder, pollen blocker creams, lipid-based ointments, microemulsions, thixotropic fluid, liposomal formulations, and so on and so forth. Not all of these have endured the test of time, though. I mentioned this one study that was carried out with microemulsions. You can see on the y-axis the change in morning total nasal symptom score. And this is microemulsion with the solid squares. And there's the open squares, which show the physiological saline days. It was a double-blind study. And you can see clearly the difference in symptom scores between the protective microemulsions and the placebo or physiologic saline treatment group. These findings suggest the possibility that topical microemulsions can be a useful option to reduce nasal mucosal exposure to allergen in perennial allergic rhinitis. Now, we have plenty of studies with one specific product, which is the subject of tonight's webinar. And this is methylcellulose powder for prevention and management of nasal symptoms. We have a relatively long history now of research done with this substance, and this is the Nasact, which you are already getting to start familiar with. And there's a good rationale to use this substance. So first, it's an important message from ARIA, states that all patients with allergic rhinitis should be instructed to try to avoid allergens. And this methylcellulose is one of the good potential candidates to ensure one such good barrier enforcement measure, because it's made out of microcrystals, and when you squeeze the little bottle which contains it, and this is a patented technology, there's a little cloud that comes out of the nozzle of the bottle, and the microcrystals, which are part of the cloud, when they come in touch with the moisture on the nasal mucosal surface, they make a gel on top of the physiological Zollen gel lining of the mucosa, and then they become a barrier to all those different allergens, irritants, indoor and outdoor pollutants, microorganisms. And this seems to be a very good approach in preventing nasal symptoms. And there's plenty of information in this overview, and I certainly recommend to Radial Sun Pharma to make you familiar with this overview, because it contains all the important data. So this can be achieved by seclusion in places devoid of the offending allergens, which is not feasible for people leading an active life. This means that you can't stay in one place, just protecting yourself from the ambient environment. So the so-called barrier enforcement measures can be implemented, which is directly to protect the nasal mucosa by blocking the contact with potentially harmful substances like allergens and particulate matter. So what makes the NASAC content so useful? This is cellulose. Cellulose is the most abundant natural polymer in nature. It's all natural, and there are hundreds and hundreds of different grades and concentrations and different modifications of cellulose. Methyl cellulose, the NASAC that we are talking about, is chemically defined as hydroxypropyl methyl cellulose. It's a polymer itself. It's not just any polymer. It's a very special polymer which is being treated in a specific way in order to achieve the microcrystals that I mentioned a little bit earlier. And methyl cellulose, or NASAC, or HPMC as it's known, this is the formula here. This is the side chains that make it so special and specific. It has this property this is the kind of powder that you see in the bottle. You see the scale here. When you have it mix up with some moisture on the mucosa, it turns into a very dense pavement. This is what becomes. This is the kind of gel that you can see after the powder has turned into gel. So there's basically no entry for the harmful substances, particles, specks of dust and mites and so on and so forth. And this has been proven in a very elegant experiment which was done at the time by Jean Amberlin and her co-worker, and it's an in vitro setup. This is the kind of setup that they used. This is microslip with agar gel here. There's this well where you put the allergen, and the allergen used in that particular setup was Dermatophagoides terronicinus 1. And then there was this area which was filled up with the gel made up by dissolving 0.2 milliliters of gel from 50 micrograms powder with 1 milliliter saline. And this was repeated with another gel that wasn't made of cellulose, which was the control for this experiment. What was the result of this test? Diffusion of allergen through this NASAC layer showed a significant reduction in all points of time. After 15 minutes, only 0.76% of the baseline amount had diffused through. After 360 minutes, that's 6 hours, only 14% had diffused through. With the control gel that was made out of lactose, it was 100% diffusion right at the very beginning of the experiment. The mesh size in the NASAC gel is notably smaller than most other gels. And there's a whole range now of different clinical studies that have demonstrated the utility of the clinical utility of using the gel. I'll start with the first clinical study that was published in 2003 by Peter Josling and his co-worker Stedman. And they used 102 hay fever volunteers. They used the 5-point scoring system to grade their general well-being and severity in any hay fever attacks. And they concluded that overall, 77% of the volunteers reported a significant reduction in the number of symptomatic episodes throughout the study period. Some subjects graded HPMC or NASAC as more effective and reported fewer side effects than pharmacological, pharmaceutical treatments. Now I'll run through the other studies which are with very similar outcomes at a quicker pace, because I'll be reiterating the same message, that the symptom scores that have been recorded with the methylcellulose or NASAC can demonstrate a significant effect on reducing of some and basically the important symptoms like rhinorrhea and congestion in patients with persistent rhinitis due to house dust mite allergy. That was the study of Amberlin and Lewis. And there's a sequence of studies, a couple of studies made in children and in adults by Niels Åberg and his co-workers in Sweden, and one other study in Ukraine where Niels was the lead author. And they demonstrated that in double-blind placebo-controlled trials where they read the symptom scores, they sent reminders and reporting on symptom scores by SMS on mobile phones. And you can see on the graph here, on the Y1 axis, you have this dotted line where you have the pollen of birch concentrations in the air. You have this area under the placebo group, and you have the continuous line here with the active group where they used on daily basis NASAC. And this was throughout a period of 20 days. And you can visibly see the difference between the placebo area under the curve and the active group area under the curve. So the conclusion was that the NASAC reduces symptoms in seasonal allergic rhinitis in children and adolescents. And that was the same conclusion in adults. The study was done following the same study design in 108 adult patients between 18 and 40 years. Again, mobile phones were used for reminders and for reporting symptoms. And you can clearly see the curves that respond to the active treatment arm and to the placebo arm. There was a highly significant difference in those subjects with seasonal allergic rhinitis. So NASAC provided significant protection against all seasonal allergic rhinitis symptoms in grass pollen sensitized adults. And I want to emphasize another point here. This was a study that we did in my clinic, and we had 2 arms, and we wanted to see whether whether Nasact is nasalese, as it's called in many countries in Europe, whether Nasact will have a beneficial synergy effect with the different decongestants and other nasal drugs applied locally. So we had an arm with oxymetazoline, that's a decongestant that we used in patients for 8 days in those two different arms of the study. And after applying oxymetazoline, we puffed in Nasact, methylcellulose, or placebo in those patients, and they were allowed to use rescue medications in the meantime. And we read the outcomes on day 8. Then they remained without rescue medication, only on rescue medications without nasalese or placebo or with oxymetazoline. And we had another run of workup tests on day 15. So we used peak nasal inspiratory flow. We also documented subjective symptoms on visual analog scale in diaries. But the important thing is that we did this peak nasal inspiratory flow follow-up on day 1, before actually the start of the study. So this was the baseline patency of the noses of the patients. And this was the Nasact blue curve, followed in the course of 360 minutes at regular intervals. And this was the placebo, the curve of the nasal patency under the placebo. So at the end of those 6 hours that patients were followed up, you can see how the scissors opens. You see the difference, the significant difference between the two arms of the study. And we repeated that at day 7, 1 week after treatment. The starting point was different, and there was clear-cut, very significant difference between patients on Nasact and patients on placebo in terms of this area under the curve on the basis of the measurement of peak nasal inspiratory flow for 6 hours. Interestingly, on day 15, after Nasact and placebo were disconnected, there was this unexpected difference between the peak nasal inspiratory flow, which means, at least we interpret it like that, that Nasact could have had another healing beneficial effect that carried on for another week after its discontinuation. So Nasact or methylcellulose is meant to provide mechanical barrier between nasal mucosa and environmental noxi. It prevents allergens and particulate matter from reaching the nasal mucosa. This is, once again, I repeat it, barrier-enforcing effect. Clinical studies have provided evidence of the effectiveness of methylcellulose in adults and children with seasonal and perennial persistent allergic rhinitis. And methylcellulose possesses mucoadhesive properties, and when applied after nasal drugs, can prolong their stay in the nose, thus enhancing their effectiveness or efficacy in that case. So I conclude here with the management slide that has been copied from the ARIA guidelines. You know this division between intermittent and persistent allergic rhinitis, and there's a strict algorithm of how you treat mild rhinitis, where you can use H1 blockers intranasal H1 blockers, where you can also add on in the moderate intermittent rhinitis and the mild persistent rhinitis, some nasal anti-inflammatories. And you have all the different measures that you can use in the severe forms of the disease. But on the bottom here, the basis for all this management scheme is the allergen and irritant avoidance, which is and can be very appropriate. And what can we achieve with the methylcellulose, with the NASACT? So nasal drug enhancement, we can rely on it in many patients, and it's a cheap way of making best use of nasal medications. We can enhance the effectiveness of a decongestant, which we basically cannot carry on for a long period of time. We can increase the effectiveness of antihistamine when you have rhinorrhea, or you can increase the effectiveness and anticholinergic in cases of extreme rhinorrhea. You can certainly have as basis of this triangle the mucosal barrier enforcement effect, and you could have also the corticosteroid nasal application, which could be further enhanced by methylcellulose or NASACT. And with this, I conclude my presentation. I want to thank Radial Sun Pharma for supporting this webinar. I hope that I didn't put you to sleep with my talk, and I'm certain that you'll appreciate the benefits that you can derive from one such very, very interesting natural product that has no major side effects and that people would love just for the sake of being natural. Thank you so much.
Thank you, Dr. Popov, for the lucid presentation. It was very informative indeed. I think it's now time to start our Q&A session. I request all the delegates to put forth your question through the portal. We have only 15 minutes for the Q&A session. So there are some questions which have already come in, Dr. Popov. So I think we can start with one of those. So the first question is, can NASACT cause sneezing since it is a powder? And a related question to that is, can it cause nasal stuffiness as well?
Certainly, anything that you put in the nose, which is a very sensitive area, can cause sneezing. And this could be the case. People can sneeze and blow out the NASACT that has been puffed into the nose. But this is the beauty of it. Once you know that there's no drug inside this product, you can just blow your nose and put the powder again. The second time, usually, people wouldn't sneeze because they would be desensitized, so to say, by just puffing the powder the first time. As opposed to that, congestion is not very likely because there's no mechanisms that would necessarily lead to congestion. Congestion is a slower pathogenetic process, and just puffing in nasally NASACT wouldn't lead to congestion. At least this is my experience.